So just for a little bit of orientation this morning, I'd like to introduce Wendy Boychuk. So Wendy kindly came to go on this little journey with us. She's works for the WeightWise program and does training, a lot of training, a lot of teaching for providers and for patients. So she teaches obesity level 1 and 2, and teaches all the WeightWise module programs to patients, and has been really involved with education around this topic for the last 3 years. And then before that, she was working in the HEART program, which is the Healthy Aging
Resource team.
I still haven't figured it out. Healthy Aging Resource team. And in that role, she was there for about 10 years, doing illness prevention and chronic disease management with the elderly. And then before that, you were in home care. Mm-hmm. And then before that, she had kids. And then before that, she was teaching in nursing school. And then before that, she was in nursing. So doing all of the.
Wow, I sound really old.
But she has a wealth of experience to bring to the table. And what we want to do is we're going to hear from Wendy to kick things off a little bit, with some materials. And what the team's put together for you for today, the binder, is a bunch of different tools and things that Wendy has found useful for different aspects of assessment. So just so that you have those in your binders in your back pocket. And you may find that for different that you see that they may be helpful and things you want to pull out. So we wanted to share those with you, but we're not going to be going through those exhaustively today because that's not the principal focus. So Wendy's going to talk to us a little bit, and then Robin and I are going to model a couple of little ideas that we came up with in terms of things. We'll debrief about that a little bit. Then we're going to divide you guys up into groups. Not necessarily role play. We have some scenarios. You could role play and practice a little bit, and I would encourage you to do that a little bit with some of the tools. But also we want you to get your fingers on the tools and think about how you could make them work in encounters, and then we'll bring everybody back and get some feedback. And then the other thing we want to achieve today is talk a little bit about the Learn Collaborative breakout groups. That came out a little bit last session, and we have a couple of ideas there. So we want to round up with some resolution about how we're going to push that forward. Now, a bunch of colleagues can't be here today because they're doing their chronic illness training. There's some chronic disease training right now. So we'll take all the feedback from you guys, and we'll make sure that we disseminate it to those guys and also get their input and thoughts on it. But hopefully we can get some good momentum from the group today and go from there. So that's what we want to do. So I'm going to turn it over to Wendy and from there.
All right. Well, thanks for having me here. I've been here once before doing weight bias, so it's nice to be back. I was asked, as I said, to come and talk to you about assessment tools, and more specifically, look at the 5 A's. Talk about the A of assess. So what are we looking for there? I know you guys are looking for ways that you can feel like you've achieved something in those 10 minutes with patients. So when I talk about assess, I'll go over those core pieces of assess, those root causes. They've also asked me to spend some time really going over the 4 M's, and I've wrestled quite a bit with that. How do you make those root causes on that 5 A's handout and the 4 M's all work together when we're with patients? So I'll go through that, and as I said, I brought some case studies for you guys to work on, some journal entries, days worth of journal entries, that sort of thing. So we'll go through all of that together. Okay, it's going to be one of those days. I'm not sure where it wants me to lean to make this happen. There we go. There we go. There we go. Okay, so when we're looking at the 5 A's, readiness is actually under ask, but I'll start with that because it kind of leads me into one of the first tools. So a lot of patients come and they want to lose weight. They say, yeah, I'm ready to lose weight. But what I've learned is being ready to lose weight is not the same as being ready to make lifestyle changes. And that's important because weight loss is actually not a behavior. right? So being ready to lose weight isn't the same as being ready to do anything. You can't say, I'm going to leave here and I'm going to do 20 minutes of weight loss. You can pick lifestyle changes that you want to make, that if you do them over and over and over, then you should achieve weight loss if we've all done our job well. So that's why when assessing readiness, we really need to look at what are they actually ready to do, and that can be quite different. So in the materials that I sent, I did send a readiness questionnaire. And it does start out with questions that say, how motivated are you to lose weight? How confident are you? What's your goals? What are you, so you get an idea of their goals and expectations. That's a nice way to start, but the reality is when you're sitting with that patient, when you get to that place in your assessment where you're ready to do, you should be assessing readiness, not are you ready to lose weight, but how ready are you to make that behavior change. So what I mean is, they might be ready to work on their time management skills, which is going to help them to, say actually get a lunch pack, but they might not be ready to work on changing their activity level. So it needs to be, when you're assessing readiness, it really needs to be behavior specific, and they'll probably save you a lot of time. Another thing that I liked about this tool was you could fill it out ahead of time. So this doesn't necessarily have to take up any clinic time for you. They can just go through, what are the things that they think have caused them to gain weight? And what are the things that they think are barriers to them losing weight? So that gives you some targeted areas right away. To me, that's one of the best things that we can do to move things along. So what do you think has caused you to gain weight? What do you think that you'd like to work on? And most people know. They know what they're ready to work on, what they're not interested in looking at. And then on the back, it also has a little bit of, so how much time are you actually willing to put into this in a day? Can you put in half an hour? If you can't put in any time at all to make any lifestyle changes, it's going to be really hard to actually get anywhere. So I think that's a nice little tool for getting you started. Expectations. That's another thing that can be difficult, right? You get that patient in there, and yes, they like to lose weight, and often studies show that most patients would like to lose about 32% of their total body weight. Well, that's expecting surgical type results from lifestyle change. So I don't know about you guys, but a lot of my patients find it really disheartening when I say, well, actually it's realistic for you to lose somewhere between 5 to 10% and keep it off, and even that is really hard. So that can be difficult, and maybe an early part of the conversation, and what you're hoping to achieve, and then moving it into less of weight loss, but what are you actually hoping to achieve with this weight loss? What are the things that are bothering you about your weight? What are you hoping that weight loss will do for you? And then that can help you sort of match more realistic expectations. So if what they're hoping is that they get rid of some of the pain in their knee joints, then telling them that losing 1 pound of weight usually takes about 4 pounds of pressure off your knees and 6 pounds off your hips. Oh wow. Now suddenly that's a lot more, I can do a small thing and get a big result. So focusing getting past the weight to what are they really hoping or expecting to get from weight loss, maybe will help get some buy-in from them. Lots of patients use those, for when they're trying to decide where they want to go. They just use our BMI charts, or those kind of charts that tell them what their weight should be. And maybe having a conversation about those charts are just for, they're not really supposed to help you figure out what you should weigh. They have other purposes. They're to guide us to, BMI charts are really just to tell us, are you in a risk category? Should I assess further? That sort of thing. So that can help. Bringing out the Edmonton obesity, like the EOS, can help you when you're trying to decide how important is weight loss, how is their weight affecting their health, and where are you looking for your results to come from. So when we look at the 5A tool, we have the root causes along the bottom, and that's what I'm going to start with. So I'm not sure if you have the tool exactly like this, but I've been told that you're all used to the tool. All right, so I just like to start at the bottom because it just makes more sense to me. So when we start with our assessment, we've gone over ask. There's the assess piece in the 5 A's checklist. I'm not going to cover how to assess BMI and waist circumference and plot them on the obesity staging system, because I think you guys are fairly comfortable with that. Am I correct? So I want to go over a little more about identifying your patient's root causes of weight gain, and then go on to discuss the 4 M's. All right, give you a second there. Okay, so when we look at the root causes of weight gain, is everyone good with their stuff? When we look at, sorry, I don't want to talk when you're trying to find your things. When we look at the root causes of weight gain, really we're saying, is the weight gain due to increased food intake, or is it due to decreased activity, or is it due to a change in their metabolism, a slower metabolism? That's important because that's how you get weight gain, right? When any one of those elements or more than one of them change, if the change means that there's a net retention of calories, that's what we get is weight gain, right? So that's how we want to look first at the root causes. But you've probably noticed that if you just target the root causes with your patient, if you just say, well, okay, well, let's change, get you eating less, get you moving more, we don't always have a lot of success with that, right? That old eat less, move more strategy, while definitely some of those things are part of weight management for our patient, lots of times we don't have success with only that because we're not looking at what are those things that are actually affecting the root causes. What are those comorbidities, confounders that make it difficult for them to make changes in the root causes, and that's where the 4 M's come in. Those are those things that might become barriers to your patients actually making changes in that. So I want to go through the root causes first, and I'll start with that idea of food intake. And I know won't spend a whole lot of time on this one, but I did put in the package one called a checklist to assess food intake. This is just if you're looking for a quick tool for your patients, and the way this one works is you ask your patients to bring you in a 1-day food record. And if you want to try that later today, I'm not sure if that's part of their plan, but I did bring 1-day food records for the case studies if you want to give it a try. So when you look at this tool, the instructions are, like I said, complete a full day, and then it gives you the thing to target. When you're looking at that food record, sometimes providers tell me, I look at the food record, but I'm not really sure what to do with it, other than, we always want to say, good job, you're actually doing a food record. It's always a great place to start. Whatever they've got there, that's great to have something to work with, but it just gives you some things to be looking at. Are they eating breakfast? Are they eating are they eating 4 or 5 times a day? Those kind of things, and I won't read through it for you. And then on the other side, it gives you, from your answers of that, so what kind of a guiding advice can I give them? How can I give them some tips to start eating breakfast, or how can I give them some tips to get more fiber in the meal? And then it's got just a nice little box on it for you to actually turn that into a SMART goal. So I find with one of my kind of overall mantras with patients is nobody can change more than 1 or 2 lifestyle things at a time. Really, you give your patient 15 things to do when they leave, they're going to do 1 or 2. So you might as well pick what are the 1 or 2 things that you want to work on, and let's work on that until next time. So if this is what they want to work on, then it gives you a nice little thing to start with. Does that make sense? All right. So that is one way to look at changing their intake. Physical activity. If they've said that they want to work on their physical activity, decreased physical activity, activity is another root cause of weight gain. So we would like to look at assessing that. So if we have our client with us and they think that they want to talk about activity, then how do we do that? Well, we can look at things like asking them, what's your current activity? And we need to go a little bit further than, what do? You want to find out, I don't know if you guys use the FIT formula, that's how it's stuck in my head, but what are they doing? And, how often? So frequency, intensity, time, and type. So what are you doing? How often are you doing that? How hard are you working while you're doing that? Often I start out by asking people, so what do you like to do? And as people, they do tend to the things that they really like. So sometimes it's just, what did you used to like to do? Or what are you hoping to be able to do again? And that gives them something to target for. And people usually have an idea, I really want to be able to ski again. I really want to be able to golf again. And then, can we break that down so that we're getting to some of the behaviors that will get us closer to you being able to do that? Are there ways that that they can just increase their lifestyle activity? So are there ways that they can increase just the activity if they're not ready to actually exercise? Are there ways that they can just add more activity into their day? Can they get off the bus earlier? All of those things that we all know, but they can be turned into nice, doable, bite-sized SMART goals for them so that they really, are getting started to work on something. What are their physical activity resources? What are they actually able to do? Do they have equipment at home that they can use? Are they willing to try? Do they have any medical conditions that are getting in the way of them doing what they want to do? And we'll talk about some of those when we talk about the 4 M's, because those are the things that are going to get in the way of them doing what it is that they want to do. And then lastly, what are their beliefs about physical activity? If they believe that physical activity is not for them, or if they believe that physical activity is not going to work for them, then it's going to be really hard to do anything to change that. So our job then is really to reinforce what are the positive benefits for them and what are realistic benefits that they can get from an exercise program. And in your package of handouts, I've put a plan called My Activity Plan in there. And we use this when we work with patients in our activity workshop, and it just gives them a way to think about what am I currently doing now. We try to get everyone wearing a pedometer as a start out so they can just figure out what they are doing, then making a realistic plan of increasing those daily steps at maybe 5 to 10% a day per week, going more than 10%. Kind of structured activity would they like to try if they're ready for that, if we're ready to go beyond basic structured activity plan for people that are ready for that. And then, what are the things that they're hoping to get out of that? So that's, something that you can pull out and use with your patient. You might find that helpful when you're thinking about physical activity targets. Some people are not willing to try anything, and sometimes it's because they have this barrier in their mind that if I'm going to be physically active, I have to be like Biggest Loser physically active, right? It's not going to work if I don't do, an hour and a half in the gym a day. And so they find it quite a bit of relief when we say to them, no, really, what you're trying to achieve is the right amount of activity for you is when you feel happy with the time you're putting in and the results that you're getting out. And whatever that is for you, and then probably will change over time, that's what we're going to target. Because it's got to be positive and it's got to be pleasant, otherwise it's not going to be sustainable. Right? They've got to like it. So start with that. It's actually okay just to pick something you like, even if it's the thing that doesn't get you the biggest calorie burn you ever heard of. It's actually a great place to start. So finding something for them that's realistic and sustainable is really the place to target. So the third root cause there then is metabolism. So a lot of things can affect your patient's metabolism, and sometimes they'll say to you, well, I eat the same way I always did, and I'm the same activity that I always was, and the weight is still going on. So if that really does seem to be the case, looking at food records or whatever it is, then there probably is something going on with their metabolism. And so many things can affect people's metabolism. And I find it a little confusing. I don't know about you guys, but metabolism is in root causes, and then there's also metabolism in one of the 4 M's. And so I've kind of wrestled with how do I split this up. And in my head, the way that I now split it up is under metabolism in the 4 M's, that's where we're talking about actual disease processes that affect metabolism, whereas root causes, the metabolism that's under there, is more the things that affect all of us, if that makes sense. So I don't know how much you guys want me to go into this, because I'm so nursey. I could talk about all the metabolism things on and on and on, so I'll try not to. But muscle mass does change with age, right? And muscle mass is different by gender. So we know that less muscle mass means lower metabolism. Right? So the differences in gender would be a man and a woman of the same height and weight. A man would probably have a metabolic rate about 5 to 10% higher, just because men have higher muscle mass. So that's why you get those patients, I don't know if you've had them, but I have them, where the husband and wife come in, and she's like, well, we started a diet together, and I lost an ounce, and he lost 15 pounds, and we're doing the same thing, and how unfair is that? And a lot of that is just, they just can lose the weight faster because of that higher level of muscle mass. We know that muscle mass decreases with age, and our metabolism decreases with age, and it decreases about 2 to 3% per decade. So that means per decade of age, a woman will just need about 70 less calories per decade, and a man will need about 100 less calories per decade. So yeah, we can't just be the same and move the same as we did 10 years ago, expect to not gain weight. That makes sense? So something has to change. Weight loss and yo-yo dieting, that can be a big factor, because as you lose weight, you will eventually hit a point where the new amount that you're moving and the new amount you're eating is what your body needs, and you'll sustain. But people that are yo-yo dieters, it's actually healthier for them to stay at a bit of a higher weight than to keep sort of going with these peaks and valleys. Because what happens with people that have been on several diets, and I see this a lot, by the time people get to weight-wise, they've been on 5, 6, 7, 8 diets, and say, oh, I'm super awesome at losing weight, but I'm just as super awesome at gaining weight. So, but unfortunately, when you lose weight, a percentage of the weight that you lose will be muscle mass, right? You'll lose like 14 to 23% of your weight loss will be muscle mass. But when you regain, you won't regain 14 to 20%. So you may be the same weight you were before, but you won't be the same body composition, and you won't have as high of a basal metabolic rate because you don't have the same amount of muscle. So this is where it's important to caution people when they really want to go on these diets that promise quick weight loss, that it is not in their best interest, because you want to maintain the muscle mass. So that's why you don't want to do that. Makes sense? All right. People's health status makes a difference, right? Anything any medication changes or anything where your patient's heart rate goes down, right? If your heart rate goes down with medications, then you're not burning as much at rest. Patients that have respiratory conditions, so they're going to be breathing slower. They might have less of a metabolism. Pregnancy, people that gain weight with pregnancies, especially if they have pregnancies where they haven't re-lost all the weight, it's definitely harder for them to get that weight off. Endocrine disorders. So a lot of endocrine disorders can have an effect with weight. One that I see a lot is PCOS, polycystic ovarian syndrome, and makes it difficult to lose weight. But on the plus side of that, when people lose weight when they have PCOS, it can really help their PCOS. It helps with improves the insulin resistance piece. So it's worth trying to get that weight loss for those people. Genetics, well, everybody's different. We know when people stop smoking that they tend to gain weight, and it's a little bit higher, unfortunately, than some of the smoking studies show us. So they can sort of gain up to 7 kilograms from stopping smoking. One of the reasons is because your metabolic rate drops when you stop smoking, right? And it's just not as high. We see sleep as a real problem these days. If people aren't sleeping well, you almost have to deal with that before anything else, because, well, if you had a crappy night's sleep and then you went to work the next day and you get home, do you really want to go to the gym, make that great dinner, pack the lunch? No, you don't. You want carbs in the remote because you're tired. So really, for people with, and we'll talk about it under the 4Ms, for people with the sleep things, sleep apnea, all that, sleep is a big deal. Sleep also, if you don't sleep well, actually changes your hormones. You actually produce more ghrelin the next day. You're hungrier if you don't sleep well. You don't sleep well for several days, changes your leptin. You don't feel as satisfied. So not sleeping is a big factor, and I always say if people think they've got sleep apnea, they should probably get that dealt with sooner as opposed to later. Medications, any medications, some medications can change our metabolic rates, but I think sometimes we also forget that some medications can change the other two root causes as well, right? Some medications make us hungrier, and some medications make it hard to be as active. Like I have patients say, I went on this medication and my joints were so achy that someone told me that this week, and I can't remember which medication they were on. They said their joints were so achy they weren't moving at all. And so they started to gain weight again just because their activity level went down. And so they went in and so their doc got the medication changed and they're way better and being active again. So sometimes the funniest little things are affecting some of those root causes. So those are all of the basics of the root causes. And lots to look at. I know you guys don't want to be spending all of your time in assessment. So really, I wouldn't say, go through tools and assess all of these little things. It's just good to have that thinking in your mind that that's there. And then we want to look at those 4 M's. So again, on your 5A's checklist, that's the ones across the top here. So obesity is considered both a chronic disease and a contributor to other conditions. And it can be a complication. Other things can complicate it. It can be a barrier to all of the things in the 4Ms, and things that come under the 4Ms can be a barrier to dealing with obesity. So it is good to spend some time looking at the things that fall under these 4Ms, the mental, mechanical, metabolic, and monetary things. So I want to look at those because those are the things that if you identify them early, it can really help you with the treatment. And conversely, if you've been trying to work on those root causes and it's just not working, you probably need to go to the 4Ms. You probably need to see, is something going on here that's getting in the way of me doing this? So I want to go to, and I want it to go, and we'll start with mental. So that's the first M is mental health. So obesity itself doesn't constitute a mental health condition, but individuals that have obesity do have a higher prevalence of mental health concerns than just the general population at large. So obesity contributes to the incidence and to the severity of mental health conditions, and mental health conditions contribute to obesity. So there's a lot of bidirectionality going on there. So treatment for both is indicated. You need to be treating the mental health conditions and treating obesity. So how do we do that? Well, as nurses and other frontline providers, there's things that we can do. We don't need to always just make that referral to mental health, although there's a great time to do that. So patients can have challenges in 3 areas with respect to weight management. So I'll break them down into 3 categories. The first, mental health, or I guess psychological behavioral piece that they could have trouble with, is those cognitive or skill-based challenges. So those are things like, do they understand the principles behind weight management? Are they actually able to understand how to count calories? Are they actually able to do they have basic cooking skills? Do they understand how to substitute lower calorie ingredients for higher calorie ingredients? So, do you need to make a referral or work on can they get some of those basic skills that maybe are getting in the way of them being able to follow through? And the same would be for physical activity. Do they really understand how to get the movement in and those kind of things? The second set of challenges are the emotionally based challenges or the psychologically based challenges. So these are any of the mental health conditions. So this would be things like depression, anxiety, eating disorders, especially binge eating disorder, or are they maybe eating to improve their mood? So what I kind of call they're self-medicating with food to feel better, or to kind of get rid of any of those uncomfortable mood states. So that's our second category. And the last is those behavioral-based challenges. So these are things like, are they just eating in response to habits? Kids are in bed, it's 8 o'clock, it's my time, I relax and food helps me do that. Do they just respond to a lot of visual cues in their environment? Do they just have like a really super duper awesome social life that includes a lot of food and being out all the time, and you need to help them work on that? Is it just that they have problems maybe with their routine? It's just a crazy busy life and they need to work on that. So sometimes it's difficult to figure out what are the actual challenges going on there. What are your patients experiencing? I don't know if you've found that, but you get that patient and you're like, this just isn't working, right? Why is this not working? They keep coming back and we agreed on these goals and they keep coming back and nothing's different. Do you have that happen? Yeah, so I put in one handout that I thought was kind of nice. If that happens to you. So if the patients, it just kind of gives examples about what things your patient might be saying and some ideas of what it might tweak. So for example, if we go down to memory, if your patient's always coming back and they're saying things like, oh, I forgot my journal, or I forgot to journal, or you never said that. I don't remember you ever, us ever having this conversation. Then it just leads you to what kind of things you might want to look up. Check their motivation. Is this actually something that they really want to do, or is it just something you wanted them to do? Maybe they're depressed. Maybe you need to do a screen for depression. Screen for ADHD. We're often surprised, and we often surprise people by letting them, when we do screens for ADHD, that people have really high rates of ADHD with obesity. And I can't tell you how many times people say, wow, I'm 52 years old and I just finding out that I have ADHD. I just thought it was a really awesome kindergarten teacher because I'm so fun. So that's really common. So hopefully you'll like that tool. So these are some of those mental health challenges that we can have. So depending on the mental health condition, one of the it could be any one of these challenges. So we could be looking for impairments in things like their capacity to organize their day. Maybe they have difficulty organizing a meal, maybe difficulty getting that regular exercise schedule. Sometimes with mental health issues, it's actually just a problem with overall energy level. With some of the depressions and anxiety, it can actually be really exhausting to have an anxiety condition. So sometimes just all the things that we're asking them to do, it's just hard to get the energy to do it. So with some of these mental health conditions, you can see quite a fluctuation in how much energy a patient has. So these are the common mental health concerns that I had talked about a little bit, and I did put some different tools in your package for you. So for depression screens, there's a link in there for some different depression screens that you could look at. There's a generalized anxiety screen. So these are all screens that can be done by a nurse that don't, as long as you're comfortable with it. before you decide if you want to refer or not, because they're not diagnostic, right? They're just risk indicators. You're just seeing, does this person seem to be at a risk for an anxiety disorder? There's a binge eating disorder questionnaire in there. There's the adult ADHD, that's a hard one to say, ADHD form in there. My formatting wasn't perfect, so I'm not sure how you got it. All right, so when we do those things, if that's what we're thinking, then we want to think about, how do I know when I need to refer? I think this is an issue for a lot of people. When do I refer these people? So you've done your screens. So things like when the patient's distress is really out of proportion for the situation. There might be something else going on. If the symptoms seem to be prolonged and ongoing, if there's severe impairment, so if it's getting in the way of their family, their personal life, their work, their ability to function. If you suspect that there's mental health barriers that really seem beyond your capacity to deal with, then refer that patient, or of course, if they have suicidal behaviors or risk-taking behaviors are present, then a referral would be good. All right, so that's all I'm going to say about mental health. Then I want to move on to those other barriers like mechanical and metabolic. So this is just a really quick slide to say there's just so many ways that obesity can affect our patients and affect their conditions, and conditions that can affect their weight and their ability to do weight management. So we'll start out, and a lot of them are mechanical. So that's our second M. And it really does work both ways. I talked a little bit about things like sleep apnea. So a lot of these conditions can be lessened, or they can be prevented by incorporating some healthy, active lifestyle things. But some of the conditions can make incorporating a healthy, active lifestyle more difficult, right? If you're in pain, you don't really want to be moving as much. So definitely that's why these things are important, just to know that they're there as barriers, that they're there as things that can be getting in the way of actually getting at those root causes. So I did put a sleepiness scale in there. You guys probably use one of your own. I'm just going to quickly do the last few slides here so that we have time to get on to doing some of the work here. So a little bit about functional concerns. Just that lots of times patients won't tell you, especially about the personal hygiene issues, if you don't ask. Especially as nurses, lots of patients with excess weight do have skin issues and mobility issues that they're not going to tell you about until they know you quite well. So just not forgetting to ask about those things. And that, do you have OTs? Okay, so this won't help you a whole lot, but just that there is a difference between what each of the groups can do. And I'm sure you're aware that of the different metabolic things. Monetary issues, it's just making sure that we ask them about the things that are getting in their way. You know, when we're prescribing things, can you actually afford these changes in food? If we want you to be more active, you know, what can you afford? What's reasonable? And as I said, we have some case scenarios to have a good look at all of these things. So that's all of this slide information that I want to go through with you today.
Let's take a few minutes for any questions that might have popped up just before we okay. Awesome. Thanks a million, Wendy. So, what we come on over, Rob. So we'll make this exercise a little bit quicker. But what we really want to emphasize is it's very overwhelming. And you know, I think sometimes that if weight management encounters with patients have to be something that we set time to do, and if we have this preconceived idea that we need to have a long chunk of time to do it, then that's a huge barrier for us even to start, even to open the door. So we're seeing somebody force something out, and that's not necessarily, this kind of comes up. And I know I struggle with this. You know, we typically have 5 A's. Initially it was, okay, just get it off, you can ask the question, would it be okay for us to discuss wave? And then, oh good, I can refer to Ed, or I can refer to Jennifer. Well, okay, that's one way to pop out of doing something on a short-term visit. Well, so what we were trying to figure out was, is there a way to make all of this amazing information something that we can actually operationalize in a short-term basis? So we come up with a couple of suggestions. We want to run by them. We want to show you just briefly how it works. I think what we'll do is we'll cut our scenario just around the cards. And what we did is we made these little cards. And these are just our little 4M cards as a patient tool. We'll show you how we were thinking to use them. And I didn't come up with this idea. There's a guy called Victor Montori who has some really cool tools like this for diabetes. And I was coaching on his idea. And then what this sheet is here that we'll use is this is just a sheet that the patient can take home and put on the fridge. And that we can keep in the patient's chart so that we know where we are in the conversation. And the lovely thing about primary care is that while I may only have 10 minutes, I can have 10 minutes with you 30 times. Right? So we can do this over and over and over again. But that also predicates that I remember where we were last time we had a conversation. And this is a tool to help us remember where we were so that we can pick that conversation up next time. So, oh, my husband, my coworkers. Okay. All right. So, I want to share something with you just to kind of frame our conversation because we don't have a ton of time. We can certainly look back and talk about it. So, don't think that today is the only time we have. But, can I share some tools with you that we have? Okay. So, these are these cards that we have. And the reason why I'm showing you these is that when we talk to people about their struggles around their weight, what we start to find is that there's 4 areas that can be problematic for people. And I want you just to have a little bit of a look at these and see, let's go through them and just quickly look and see if some of these might resonate with you as being issues. Okay? So we have these ones here under mechanical, different kinds of conditions. Here's time here that really, you find your sleep is okay? I wake up a little bit at night, but I go right back. So I'm a bit tired, but I wouldn't say I'm up late at night or anything like that. Oh, okay. Yeah. All right. So here's another one. Sometimes people can have issues with stress, and sometimes people are stressed. They can have emotional eating with emotional cues and things, or they could, have some of these other issues.
I'm really good about eating during the day. Like I make really healthy meals for my family, and we all eat breakfast, we eat regularly during the day. But I will say that when I'm watching TV, I'm just really tired, and so something salty and crunchy is really good when I'm watching TV. So maybe some of that. I don't know if I call it emotional eating. I think it's habit more than anything, and energy eating, lack of energy eating.
Okay. Yeah. So let's kind of keep this one on the side here. And then there's these other ones. So sometimes when people are dealing with this kind of issue, sometimes resources come into play.
Okay, if I can buy good food for my family, and if I wanted to go to the gym, I can afford to if I want.
Okay, so let's put that one aside then. And then there's these conditions. Now I know your medical history, and I know you personally don't have any of these conditions. I think you had some of that in your family.
Yeah, my dad has heart disease and diabetes.
So, does your dad's experience play in at all to sort of some things you're thinking about in terms of your desire to change your weight?
Yeah, well, I just would like to be healthy. I shouldn't say healthy. I like to stay healthy so that I get where I can, do all the things I want to travel and do stuff with my family.
Okay, so not an active issue as yet, but definitely something for us as a goal to prevent having these types of things. Okay, so we can mark those down just in terms of family history around some motivation around why. So we can mark down on this sheet that I'm going to give you to take home.
Okay.
But let's focus in on this part here. So, I just want to inquire really briefly though before we get started, because I'm a little bit concerned that you say that you've been feeling more down a little bit and not really having as much energy. Are you finding that you're enjoying your activities as much as you normally do?
Well, I used to be really involved in some different social things, and I just find I just don't have the time and the energy. It's just not as much fun anymore, so I don't. Okay. Yeah, I haven't been going.
Okay. Would you say that you're feeling depressed?
Well, depressed is somebody who needs medication.
because, you know, sometimes, especially this time of year, people do get really down. If that starts to be more of an issue and you're having more problems or less enjoyment in doing your activities, maybe we could just revisit that at intervals and make sure it's not becoming more of a problem. We do have lots